Hello and welcome to our show. I'm Dr. Israel Barkin, the Medical Director of the Prostate Cancer Research and Education Foundation. On the occasion of Prostate Cancer Awareness Month, we are bringing you a lecture by Dr. Bahn, the subject active surveillance and the use of color Doppler ultrasound to follow up patient on active surveillance. Let's go now to Dr. Bahn lecture.
Active surveillance. That means we are not foregoing any treatment for any reason. We just simply delay the treatment as long as it is reasonable, simply to avoid collateral damage and loss of blood. It is not the window of for successful therapy. This is my criteria for the candidate who could be have active surveillance. First, number 1, 2, 3 is a classical definition made by Dr. D'Amico's concept. Glycine grade should be 6 or less. We don't hardly see that glycine grade of 5, 4 anymore because of the pathological interpretation migration. But maybe up to 3+4 could be a candidate. Number 2, PSA less than 10 nanogram. But I like to use so-called PSA density. I'm going to talk about it later. And the stage of the disease, T1C to T2A is ideal, but T2B with a comorbidity. In this audience, whoever stays on staying on active surveillance, find out what kind of information you have, how many out of 10 you have information about yourself, your cancer. Okay, the positive biopsy course should be less than 1/3 of all the course taken. And the percentage of tumor invasion in the particular tissue should be less than 50%. And the PSA doubling time, that means prior to the diagnosis of the prostate cancer, how long it took your PSA become double in number. Okay, it's at least over 3 years. Slow the better, obviously, all right? But I prefer over 3 years. So that means your PSA doubled up in number in 4, 5, 6 years, then it's a very good situation. And the tumor neovascularity, that means the tumor vessel, tumor needs more supplies. So on color Doppler ultrasound, you could see more increased blood flow in addition to the black and white findings. And we don't want to see that the larger blood flow, okay? Less the better, that means. And the tumor volume, you can, there's a lot of controversy about that, the tumor volume with ultrasound, but in general, black and white underestimates prostate cancer volume compared to color Doppler ultrasound. I like to see that the cancer volume is less than 1 cc. That means 1 centimeter, 1 centimeter is 1 millimeter, 10 millimeter, 10 millimeter, 10 millimeter size. It's 1 cc. Smaller the better than this. Now, it's so much controversial. It's using PCA3 gene test, less than 25. And then I like to see that your cancer gene makeup is dichromatic. So I'm going to take a look at all the items one by one and then see how, when you are under active surveillance currently, see what kind of information your information is fitting into this category, see whether you're a good candidate or a bad candidate. Okay, so glycine grade, most important one. Glycine grade is proven to be one of the most important independent predictors for prostate cancer aggressiveness and final outcome. I like to see glycine 7, 3+4 or lower rather than higher like 8, 9, 10. And then glycine grade 6 or less is ideal, of course. Glycine grade 7 equal 3+4 may be acceptable if accompanied by significant medical comorbidity. That means you have other serious medical issue like bad heart, diabetes, stroke, on and on, then you'll be a little bit more relaxed this criteria. Or short life expectancy. That means that you are most likely you are not going to make next 10 more years, then we don't need any aggressive treatment. And then serum PSA level is important. Okay, D'Amico's criteria say, well, on the 10 logical idea, but I like to use the PSA density because your serum PSA level is related to your size of the prostate. Prostate, sometimes PSA 10, 9 would be still okay. 11 even okay, 20 maybe even okay. So that means that I want to see your actual serum blood PSA level is about 15, less than 15% of your size of the prostate. Okay, that means if your prostate length volume is about 40 cc's, I don't want to see your PSA higher than 6. However, if your prostate is 100 cc's, I don't want to see your PSA over 15. There's lots of difference. So I don't know how many of you know that your PSA density at the time of diagnosis. I'm not sure. And the etiology of the high PSA, if you have a very high PSA, most commonly enlarged PSA, we call it BPH, benign prostatic hypertrophy, is an aging process. Man gets older, that happens. Then you could have high PSA as a normal. Or prostatitis, prostate inflammation, will make the PSA go up, but often make it fluctuate. Age-traffic changes is all benign condition, mainly related with the infection, and also mainly, most importantly, prostate cancer. Per tissue, cancer excretes 10 times more PSA than normal prostate tissue. Okay? Now, what is your stage of the disease? It's important. I don't know how many of you exactly know your stage of the disease. So much busy with the slide, but just I get lots of questions about it. That's why I'm showing it. T1C. Cancer was not felt by finger, not seen by ultrasound, but anyway, have a random biopsy, they got a cancer. It's a T1C. Okay, how many your cancer is T1C? All right. Okay. T2A. Cancer is seen in 1/2 or less of one lobe, either right lobe or left lobe, and then or either felt by finger examination or seen by ultrasound. Okay, that's T2A. All right. So I know that hopefully you know that where does your cancer belong to? T2B. Cancer is more than 1/2 of the one side. T2C. Cancer is in both right and left lobes. Okay, now getting serious now, all right? T3AB, already cancer extending outside of the prostate to the capsule, that means the T3A, to the seminal vesicle, T3B. All right, it's an aggressive cancer already. T4, cancer is invading blood, neck, or rectum, or invading adjacent organ. It's a kind of locally advanced prostate cancer. For active surveillance, T1C or T2A category is ideal, but I can take T2B or T2C if you have a comorbidity or short life expectancy. However, random systemic biopsy often understates the cancer, okay, because they did not hit the target precisely. You may end up the understage cancer. Now, number of positive biopsy cores should be less than 1/3. That's fine. It is general observation that higher number of positive tissue core among biopsy specimen is associated with a large volume cancer. No brainer, right? It is based on systemic biopsy. All the literature is based on systemic biopsy because still they don't understand or recognize that the target biopsy technique. It's not targeted biopsy. That takes less number of cores. How about percentage of tissue core in the particular specimen? They like to see less than 50% in one of tissue core. The percent of core positive for cancer in biopsy specimen is strongly predictive of a tumor stage and tumor volume. There is a more invasion in particular tissue, usually associated with a large volume tumor and the advanced stage, published in 2000. It is based on random biopsy again, all right? If I take a biopsy, target biopsy for right with, usually I come up with a higher number of the tissue core invasion by the cancer. Doubling time, I like to see more than 2 years to WPSA, but people 3 years. I'm going to show some data, more details in the later part, but the Dr. Klass, very famous landmark paper on active surveillance. Out of 300 men, he watched about 8 years. There were only 2 people died of it. And these 2 men had a doubling time of less than 2 years. The PSA was doubled less than 3 years time. All other people, all still living and doing fine. There is 298 patients. Okay? So tumor neovascularity, then the tumor vessel. It is known that higher the abnormal blood flow supply to the tumor, the higher the glycine grade with aggressive biological behavior. Only color Doppler ultrasound can measure the blood flow level. So we like to see that 1 plus or less. Okay, paper published about 2003 in Europe say that the presence of the focal peripheral zone hypervascularity, there is an increased blood flow at the color Doppler ultrasound sonogram is associated with a high likelihood of prostate cancer, increased specificity to 97%, which is pretty good. How about the tumor volume and tumor location? You like to see that the tumor volume less than 1 cc, and Epstein said that larger the tumor volume, you don't get work. There's more chance of capsular penetration, seminal vesicle is invaded, lymph node is already actual metastasis, on and on and on. So bad finding. And the peripheral zone tumor, I'm going to show you what they mean, is that 80% of tumors are coming from peripheral zone, and a greater chance to have extracellular extension toward the neurovascular bundle, seminal vesicle, as you saw that in that example. And the transition zone tumor is about 20% of the tumor, usually detected late, and then with a high PSA, but will have a less aggressive biological behavior. This bluish area is front view, side view. Urethral ones in the middle, bladder here, bladder carrier, urine here, rectum. This blue area is a transition zone, more safe zone to have a prostate cancer. We worry about cancer in the peripheral zone, this whitish area, with lots of seepage. Neurovascular bundle follow neurovascular bundle to get out. Follow this tract, get the duct, and get into seminal vesicle, cause a lot of problems. Okay, so peripheral zone tumor is more serious than transition zone tumor. I hope you guys know that your cancer location was in the peripheral zone or transition zone tumor. This is example of the peripheral zone tumor. Prostate, border, is a transition zone tumor called simply inner gland versus outer gland, which is a peripheral zone. Take a look at that. Peripheral zone has a more homogeneous with white tissue, now become irregular dark tissue. Look at the color Doppler. Lots of bad blood, and this is my biopsy needle. Okay? All right? That's the peripheral zone tumor, more dangerous tumor. And then transition zone tumor is in the gland, bluish area. Okay? And then take a look at this case. Border right here is a transition zone. Peripheral zone is pretty good. In transition zone, there's a dark spot, and there's some blood flow, biopsy. Even though it's a large body tumor, I would have this tumor than the other. Okay? And then this is another beauty of this showing that how targeted biopsy can do it. This gentleman came in with 2 negative biopsy, but case is going a little bit inching up. Look at that small volume tumor at apex toward the tip, and then take a look at the blood flow. Even though very small, lots of blood flow, you must target it, otherwise you have high chance. There will be high chance of missing it. That happened twice to me already. Okay.
This was part 1 of the lecture given by Dr. Duke Bahn. Please see part 2 of the lecture about active surveillance. Thank you.